Hello, and thanks very much for the invitation to speak at the Limits. Today I'd like to talk about the role of autoimmune kidney disease and inflammation in the kidney on cardiovascular disease, and specifically focusing on the role of treatment. A number of observational studies have shown over the last few years that there is an increased risk of cardiovascular disease in patients who have autoimmune or inflammatory conditions. This observational study from the 1980s looked at 500 women with lupus and compared them to an age-matched control population from the Framingham Offspring study, and showed there was a significantly increased risk of developing acute myocardial infarction or angina, especially in patients who were young, who would normally be protected from cardiovascular disease. Of those who had investigations for their cardiac events, a significant proportion of them had evidence of coronary atherosclerosis. And when we look specifically at the age risk increased rate of events, we can see that in the young age groups there's a significantly higher risk of cardiovascular disease, with risk factors being age at presentation, hypercholesterolemia, a longer diagnosis of lupus, longer steroid treatment for the lupus, or being postmenopausal. Similarly, if we look at ANCA-associated vasculitis, another inflammatory autoimmune condition that tends to affect the kidney, there is a significantly increased mortality ratio compared to the normal population. And whereas in the first year the mortality is mostly due to infection or vasculitis itself, beyond the first year death is normally due to cardiovascular problems. And the risk factors identified in this cohort were younger age, worse kidney function, and increased disease activity. So if we specifically look at patients with lupus or vasculitis who have kidney involvement, we find overall in a number of studies somewhere between 3 and 8-fold increased risk of developing cardiovascular disease, and that's matched for renal function, age and gender, as well as other traditional risk factors. So what is it that's causing this increased risk? If we look at a cartoon trying to explain the etiology of vasculitis, and a similar one could be painted for lupus, we find that the neutrophil is at the center of the disease pathogenesis, degranulating, releasing proteases, inflammatory cytokines, and releasing neutrophil extracellular traps, which then are picked up by antigen-presenting cells and presented to the immune system. But it is the neutrophil degranulation that causes vascular damage and the vasculitis that we recognize. Now, in some cases, monocytes are then attracted into the tissue and stimulate not only increased antigen presentation, but also the formation of granuloma. Similarly, if we look at atheroma, we find that neutrophils are at the center of the inflammatory response causing atheroma, with nets forming, activating macrophages to release pro-inflammatory cytokines and stimulating T cells to cause plaque propagation and rupture. So if we can target inflammation in the kidney and in the vessel by targeting the neutrophil and monocyte activation, we should be able to not only improve nephritis but also improve the atheroma. But how we do this may be critical. This is the first study looking at anti-inflammatory therapy in patients with cardiovascular disease, and it showed for the first time that if you target inflammation here using an anti-IL-1 beta monoclonal antibody, there is a reduced risk of subsequent cardiovascular endpoints in patients who had elevated inflammatory markers such as high sensitivity CRP, but without any difference on the traditional risk factors such as hypercholesterolemia. However, in nephrology, we tend to use steroids as our mainstay of therapy, and it's really been a cornerstone of treatment since its isolation in the 1930s. It was first used in rheumatoid arthritis in the late 1940s, but since the 1950s, it has become established as a treatment in all forms of inflammatory kidney disease. A significant number of hospitalized patients are taking steroids, and it's fair to say that despite it being a mainstay of treatment, we don't really understand fully the best way to use this as a drug. If we look at the impact of steroids on cardiovascular disease in patients with autoimmune or inflammatory disease, so this is a post-mortem study of patients with lupus, looking at patients who had prolonged steroid treatment, short steroid treatment, or no steroid treatment alone, we found that in those patients who had steroid therapy, there was increased hypertension, cardiac fat deposition, and significantly more coronary atheroma. If This is a study looking at the impact of steroids from a GP database, looking at cardiovascular events, using a large number of patients who were treated with steroids compared to matched non-steroid users with various underlying inflammatory conditions, including ANCA vasculitis and lupus, showing that there was a significantly increased death in the patients who were treated with steroids, such that there's a 26% increase for every 5 milligrams a day of prednisolone that's used, or a 5% increase for every 1,000 milligrams over the course of a year. However, there's a problem with these data, which is that it's very difficult to prove causality, as the patients who need the most steroids are the ones who have the most inflammation. So is it the inflammation or is it the steroids that are causing the problem? We set out to try and understand the basis of this by making a model in an animal that is prone to atheroma, which is the ApoE knockout mouse, that is fed a high-fat diet and then is treated with various anti-inflammatory strategies to try and understand the impact on kidney disease and on atheroma. And we induce kidney disease in this mouse by inducing nephrotoxic nephritis, which is a well-established model of inflammatory neutrophil monocyte and T-cell mediated nephritis. So if we look at the animals on the graph on the left, showing comparing wild-type animals with nephrotoxic nephritis to the ApoE knockout mice, you see that the ApoE knockout mice have significantly more plaque in their aorta. They have a non-significant increase in the IL-6 level, and this is despite no difference in the proteinuria levels between the wild types and the ApoE knockout mice. And in the panel above, you can see the whole mount of the aortas showing the increased atheroma in the ApoE knockout mice given nephrotoxic nephritis. If we now treat some of these animals with steroids, we find that there is a significant increase in the plaque area in the prednisolone treated animals over the course of a 9-week period of treatment. And if I show you this visually, you can see that the aortas from the animals treated with prednisolone have significantly more lipid deposited in their aortas. Not only does it cause an increase in the aortic plaque, it also increases the mortality of the animals, shown here in the survival graph, significantly impacting survival of the animals, despite us not finding any differences in LDL or blood glucose levels between these groups. So what are the implications for kidney disease? It suggests that our current use of steroids may actually be augmenting the cardiovascular disease our patients have. Reducing it would be of benefit, and finding an agent that can treat both the nephritis and the atheroma may be of great benefit. And I'd like to thank Marilina Antonello, who did most of this work.